Morning, everybody. Avi Rose. As Suyen said, I'm the acting executive director of Ashby Village this summer. And I welcome you to be here. Some of you who are long familiar with Ashby Village and some of you who may be new to us. Ashby Village is an organization in the East Bay that's mobilizes older adults to support each other and to build community as we age in place. Right now, as you see, we're staying the course with virtual programs until it's safe and healthy for us to gather in person again. The sooner the better, but we're going to wait until it's safe to do it. And we have an array of social and cultural and educational programs on a regular basis, very robust array, such as the one today that you're here for about nursing home reform, presented by Ashby Village's Elder Action and by our member support team. It's part of our commitment to activate people as well as educate them. There are other events. There's one tomorrow coming up about COVID vaccine development, and there's more to come. We're also at Ashby Village looking to grow our capacity to promote and support services and programs in our very racially and socioeconomically diverse East Bay. We welcome your involvement as members, as volunteers, as donors. All of the above is great. If you wish to support financially our work, please see the link that will be in the chat. This event is free, but yes, we rely on donations to sustain us going forward, and we got a lot of work to do. So without further ado, let me introduce Roberta Pressman, who is the chair of our member support team, and she will take it from here. Thanks so much for being here.
Good morning and welcome everyone to another one of our member support wellness presentations, which we call Embracing Change. We're particularly pleased today to be co-sponsoring this very important and timely event with our Elder Action Group. And before I introduce our speakers today, I did want to let those of you who are new to the village and those of you not familiar with Ashby Village Member Support Services or Elder Action, a little bit about both these groups. So member support at Ashby Village actually consists of several parts. We have healthier aging, a program called Connections, and a program of social care. Healthier Aging attempts to keep our members healthy by encouraging everyone to stay physically active. And we have a robust hiking program with easy walks as well as more challenging ones, an aerobics program, yoga. And after this pandemic finally subsides, we'll resume our Tai Chi class, which is on hold right now. We also have a friendly visitor program, Connections, for members who are feeling socially isolated due to illness or recovery from surgery or just increasing frailty, which makes it harder for them to get out and about. And we send visitors who are happy to chat with you, take a walk, play Scrabble, or find other ways to socialize with you while you're maybe homebound. So please do ask for that service if you are in need. And lastly, our social care team is there for you in times of crisis, loss, illness, surgery. We can help you. We can get you the assistance you might need, both through our own Ashby Village volunteer services or through recommendations from our well-researched resource list for paid services in the community. So do get in touch with us if you need us, or if you're interested in volunteering, we'd love to have you on any one of our teams. You can reach us by emailing avirose@ashbyvillage.org, and he'll connect you with the services you're looking for. Thanks so much. And Marsha will now tell you about our Elder Action program.
Thank you, Roberta. Hello, everybody. Elder Action is a social justice interest group within Ashby Village. We currently have almost 100 members, and we welcome new members, whether you're part of the village in any way or not. It doesn't really matter. So if you're interested in learning more about Elder Action, the email address is elderactionnow@gmail.com. It's all lowercase and one word. Elder Action has been in existence for 3 years now, and we have been operating as task forces within Elder Action. Currently, this year, our emphases are on climate action, as well as racial justice. And the third issue that we've been working on really almost from the start and will be working on at least for another year or two is long-term services and supports. We are part of a consortium of organizations in California who are advocating for a long-term care benefit that would be universal, would cover current retirees as well as younger people. And we did succeed in getting our demand for a universal long-term services and support benefit into the governor's master plan on aging as one of the top 5 recommendations. We are now waiting for the legislature, which is going to be considering a bill next year. So we're hoping that within 2 years, maybe 3 years, we will all enjoy some help. Not a huge amount of help, but some help in paying for long-term care services, which is hugely needed. I just want to quickly go over a couple of disturbing and hard facts. Of those of us who are participating in this webinar, 70% at least are going to need long-term care services sometimes in your life. 20% will need more than 5 years of long-term care services. The cost of a nursing home is close to $100,000 a year. The cost of home care is over $50,000 a year. These are expenses that very, very few of us can afford. And very, very few of us can have or do have long-term care insurance. So this is really one of the major issues that's confronting an aging society in California and throughout the country, and actually throughout the world. So with that, I want to turn this back to Roberta, and she will introduce our speakers.
I was just responding to Sue Yin. Hi. Many of us know very little about what goes on in nursing homes. Yet many of us, as Marcia pointed out, will know a friend, a relative, a spouse, or even ourselves who may need to spend time in a nursing home. So it's important that we all get better informed, not only about the current state of nursing homes, but also what actions we might take to make the care of our most fragile citizens safer and more effective. The many deaths in nursing homes during the pandemic exposed us all to not only the poor state of infection control, but it also exposed problems of neglect and sexual abuse present in too many of these facilities. Hopefully, our speakers today can provide us with the information we need to take action to help correct these problems. And now I'm pleased to introduce our 2 speakers, Michael Dark and Pauline Shatara from the California Advocates for Nursing Home Reform. Michael Dark has been a staff attorney at CANHR since 2019, after spending more than 20 years litigating consumer and investor class action cases in the federal courts. At California Advocates, he focuses on nursing home regulation and preventing nursing home neglect and abuse. Pauline Shatara has been at CANHR for 10 years and is the deputy director there with a focus on consumer education and Medicare policy. She has a particular interest in home and community-based services as an alternative to nursing homes. She also coordinates the lawyer referral service program there. She obtained her master's at San Francisco State in gerontology, where she focused her research on home and community-based services. Welcome to both of you.
Thanks so much for that kind introduction and the thoughtful preface that you gave to our program today. Again, I'm Mike Dark, staff attorney at CANHR. So pleased to be joined by my colleague, Pauline today, and to meet your membership. We hope this will be just the beginning of more relations in the future as we all go forward into a highly uncertain healthcare environment here in California and across the country. I'm going to set up the slide deck in a moment, but I wanted to sort of start by saying what we want to do this morning with all of you is to talk a little bit about the disaster of COVID in nursing homes, not just in California, but across the country, as a way of understanding what was already terribly wrong in nursing homes long before the pandemic began. I'll go through some of those important structural issues in understanding our long-term care industry in the United States. But then in a way, on a hopeful note, I'm going to pass off to Pauline, who is going to talk about first, why it is so many people wind up in nursing homes, and crucially, how people can make use of home and community-based services to stay out of it. So with that, I'm going to start up my, can you guys see this?
Not yet.
Not yet, hang on one second. I gotta share screen, bear with me. Share screen, and here we go.
Perfect.
Play from start. You guys in now?
Yep, that's good.
Okay, terrific. Sorry for being such an ingenue with screen sharing, especially now after a year of Zoom calls. So, CANHR, just a little tiny bit more about CANHR. We're a nonprofit. We were founded in 1983. Really one of the only organizations in the country, which is kind of a scandal in itself, that does advocacy for people who are in long-term care. There's a few others that specialize in things like Medicare and related services, but there are just very few organizations that do the work we do, which consists of both legislative and regulatory advocacy around rules and laws intended to prevent neglect and abuse, to improve conditions in nursing homes and the like. But we also do an awful lot of direct advocacy. And by that, I mean, we field calls from consumers all across the state, sometimes across the country, with questions for themselves, if they're residents or their family members, about what's going on in nursing homes, assisted living, continuing care, residential communities and the like. In the past, a lot of that work has focused on sort of our mainstays, which is eviction issues, neglect and abuse issues, benefits, access to Medi-Cal, access to Medicare and the like. I'll talk a little bit in a moment about exactly how that changed in the last year in a really terrifying way. But first, to put a real focus on this, we're going to be talking almost exclusively about what happens in nursing homes today. And that's partly because it was nursing homes that were really the battlefield on which this pandemic unfolded, and which took such a terrible toll on our elders and disabled people in California. So I thought it would be useful just to do a little definitional discussion so we can all keep straight what the different kinds of long-term care are that we have in this country. So at the top of the rung in terms of people requiring the least medical intervention, the least skilled care, you have independent living. So this could be someone living in their apartment or their home with the benefit maybe of home and community-based services if they're lucky, sometimes just with family helping them. And these are mostly people who don't have much difficulty or limited difficulty with activities of daily living, like bathing themselves, using the bathroom and the like. So they're still able to stay at home. And they're in many ways the luckiest sector of people, elders in California during the course of the pandemic, because they were most able to control the environment they were in. They suffered isolation, as did people elsewhere, but they didn't have to worry about COVID being brought into their home in the same way that people do living in congregate settings. Assisted living is sort of one step up in terms of the assistance people need. There are about, I want to say 6,000 assisted living facilities in California. These can range from 6-bed facilities to much, much larger facilities. And all of what they share is relatively limited care that they provide to people. They may provide some assistance with mobility, but they won't handle, for example, people who really need skilled care. They won't handle, with few exceptions, people with significant cognitive difficulties. And crucially, they're expensive. And by expensive, I mean $8,000 or $10,000 or $12,000 a month. And they don't get federal or state healthcare subsidies. So there's no Medicare subsidy for living in assisted living. There is sort of a narrow program for some people to get Medi-Cal to cover assisted living expenses, but those beds are very few and far between. And then finally, the real focus of our discussion today is going to be nursing homes. So in California, there's around 1,300 nursing homes housing about 90,000 people. Countrywide, nursing homes are about 1% of the population live in nursing homes. And what they have in common is they provide sort of significant levels of care, or they're supposed to. And by that, it could be people who need daily medication, people who are immobile, who can't get out of bed, people who need dialysis, people who have wounds, people with cognitive issues like Alzheimer's and dementia. Nursing homes are different in that there are healthcare subsidies that will cover care costs, while the facilities themselves are very expensive, as we heard earlier from Marcia, $6,000 or $8,000 or $10,000 a month easily. There are federal healthcare subsidies that are available. Medicare covers maybe up to the first 100 days, but if people need to be in nursing homes for a longer period, they very quickly exhaust their personal assets. And in general, people who are in nursing homes for a long term, like over 3 months, have to do it on Medi-Cal, which is the state version of Medicaid, which is the program that exists throughout the country. To be in Medi-Cal, you have to meet strict asset and income limitations. So it's really for poor people or people who have exhausted their assets and who are needing those federal subsidies to cover their care. Now, I talked a little bit about how, CANHR's bread and butter in the past has been abuse, neglect, regulation of nursing homes, especially problems with eviction. We see an awful lot of that. And I would say starting in about March of last year, something terrible was clearly beginning to happen. We were beginning to get calls from residents, calls from family members that were really a matter of life and death. We were getting calls from family members who were trying to see loved ones through a window, maybe in a first floor room, because they couldn't get access to the facility, and they would see, their wife, their mom, their brother turning blue, unkempt, losing weight, and they couldn't communicate with them. And in many cases, they were watching them die, and they were watching them die from a few feet away without being able to talk to them. And things really just got worse over the course of the year. We got calls from people who were trying to figure out how to bring loved ones home from nursing facilities. I got a call from a woman whose son had very significant cognitive issues. He was an adult, but he lived in a nursing home. The nursing home was full of COVID, and she was struggling kind of with a moral dilemma about whether she was being irresponsible, whether she was being a bad mother by leaving her son in this facility where he got the care that he needed. And she was 85 years old and living in a single room occupancy hotel. these were the kinds of crises that people found themselves in over the course of this year. And just one last one, on Christmas night, I got a call from a facility in Orange County where there were 43 people in a ward, all sick or dying of COVID, being cared for by a single nurse with COVID. So the nurse was very ill with COVID, trying to care for almost 50 people who were themselves sick and dying of COVID. It's hard to wrap your head around the fact that we live in what should be a first world country in the 21st century. And we're seeing conditions that maybe we haven't seen in the United States since the 19th century. And I want to walk you through what the toll was, but why it happened, and what that tells us about nursing homes and long-term care and what needs to be fixed. So first, let's start with the toll, because so much of the news coverage of COVID is driven just by big numbers. You'll hear, 50 people at this facility, 80 people at that. But if you step back and you look at the situation in the aggregate, 8% of US long-term care residents died during the COVID pandemic over the last year. In nursing homes, it's about 1 in 10 people. About 180,000 residents died of COVID. And just by way of comparison, in the Vietnam War, 60,000 US GIs died. And that's something that we still talk about to this day, as we should. I hope that we're still talking about the deaths that occurred in nursing homes in 20 or 30 or 40 years. But crucially, those numbers, as terrifying as they are still an undercount for a variety of reasons. They're an undercount because early in the pandemic, there was not very good diagnosis. And people died and they were just being sent off to the morgues without being accounted for as a COVID death. They're an undercount because lots of people actually died in hospitals. So they started out in nursing homes, but then they went to acute hospitals where they passed. Those numbers often didn't get counted. And terrifyingly, they're an undercount because lots of facilities deliberately didn't disclose, especially early in the pandemic, how many of their residents were actually dying. And they did that for business decisions because they didn't want to be a facility that was trying to attract new residents with a terrible record of COVID deaths. And so in many cases throughout the state, we saw facilities hiding the scope of the disaster that they were facing. This chart on the right really just gives you a sense of what proportion of overall fatalities in the United States over the course of the pandemic were nursing homes, which is the lower orange line. The upper blue line includes RCFEs, assisted living facilities. But remember, nursing homes are 1% of the population in the United States, but they made up about 30% of the deaths. So let's talk about why that happened, why that came to be. A really important thing I want people to absorb is that this did not have to be. It was not inevitable. And there's this kind of narrative about the biology of the virus. You even hear it today, that it's somehow inevitable that people who are old or disabled will die of this virus and we just need to kind of suck it up and absorb it as a society. That is not true. It wasn't true a year ago and it is certainly not true now. One way to realize that it's not true is to look at the experience of some facilities. I'm thinking about the Jewish Home in San Francisco or Laguna Honda, an enormous nursing home in San Francisco, which both had really low COVID deaths, very low transmission rates. So they had lots of elderly and disabled people, but they did not see the kind of crisis that erupted in most of the country. And that's partly because both of these facilities early on engaged in basic hygiene programs, not like infrared, sterilization, more like hand washing, teaching staff how to do good hand washing, how to keep instruments clean, how to keep residents apart from one another if they were to get sick. But it was also a lot about what was going wrong in the rest of the country in other facilities. And let's talk about that. About how we got to this place where we had the greatest public health crisis really unfolding in nursing homes more than any other part of society. And that really goes to the point I opened with, which is that before COVID, nursing homes were in a terrible crisis. The problem was it just wasn't getting that much attention. It wasn't on the news. People weren't very focused on it. Nursing homes are mostly closed communities in the suburbs, kind of invisible in some ways to lots of other people. But they were, even then, the most dangerous places to live and to work in the United States, more dangerous than coal mines, more dangerous than deep sea fishing. And you had phenomena like a 130% staff turnover per year. So in 1 year, you would not only turn over every single staff member once, but maybe a third more. And that's really because of the working conditions and some of the financial imperatives that go on in running nursing homes that we'll talk about in a second. And one thing too to keep in mind, because it's easy to lose track of this, is that nursing homes are really only about 50 years old. More than before the 1960s, there were not nursing homes as we know them now. If you go far enough back, you had things like almshouses, which were often religious or charitable institutions. Those evolved in the 30s during the Depression when lots of younger people wound up having to go into almshouses as well. But nursing homes, as we understand them today, were born as an industry in the 1960s, because that is when healthcare subsidies for people who are older, disabled, living in long-term care began. And I'm thinking Medicaid and Medicare. And nursing homes evolved to take that money in, allegedly in exchange for providing care to people. And we'll talk about whether that really happened. So I call that the original sin in this way. We're a capitalist country, I get that, we all get it. But there's a problem if you run healthcare as a for-profit industry. And that's because any business which has as its mission making more money has incentives to reduce expenses to juice profit lines. And in the healthcare context, the biggest place for reducing expenses and boosting profit margins is staffing. Staffing is the biggest line item on the budget of any nursing home. And so it's the first place that administrators and companies that run these places, some of them publicly traded companies, it's the first place they go to increase their margins is to decrease staff. And so what does that mean practically? So first, there's a kind of a misconception. Nursing homes, you think, well, care is being provided by nurses. No, you're lucky if there is a nurse on staff at many times in nursing homes. Most care is in fact provided by certified nursing assistants who are very poorly paid. They are not very well trained. And one way that CNAs are made to be cheap is they're not even given sick leave. And we'll come back to the consequences of that in a pandemic driven by a virus that spreads among staff. If you don't have sick leave for staff so that they can stay home and still feed their kids, they're gonna go to work sick and they're gonna infect people. We knew that going into this pandemic. So CNAs, when staff is cut, they wind up seeing 10 or 12 or maybe 15 people an hour. So that's like 3 minutes a resident for things like bathing and giving people medication and giving people food and hand washing between seeing people, right? That's the first thing that's gonna go if you have to see 15 people an hour, is stopping and washing your hands and sterilizing your trays and your instruments. And indeed, that is something that they gave up. And so what wound up happening in nursing homes throughout the country as a result is you have these overwhelmed workforces of CNAs who have terrible working conditions. They work for a matter of months at these facilities, often at 2 or 3 facilities at a time. And so family members became a key source, not just of like moral support for people living in nursing homes, but they were providing the labor for free. So if your mom or your dad or your brother or your sister was in a nursing home, people would go in, the family members would bathe them, would comb their hair, And crucially, they would feed them, because lots of people with strokes and other illnesses have trouble eating, they have trouble swallowing, and they need time and assistance just to get water down or to get food down safely without aspirating things. And so when early in the pandemic, visitation restrictions were put in place that cut off that crucial safety net of people who were going into these facilities to provide that kind of care. The result was people dying of starvation, of dehydration, of pneumonia from aspirating food, because there was no one there to help them eat. The trays would be put in front of people and then taken away full, 10 minutes away, because the CNAs did not have the time to do it, and there was no family members there to provide that kind of care. But also, sort of the corollary of bad staffing is bad infection control, because infection control requires staffing. If you want to have staff have enough time to undertake basic hygiene, even hand hygiene, hand washing, you need enough people so that the CNAs have enough time to do it. And that just wasn't possible. And so remember, going into the pandemic, going into the horrible year, starting in March, April of last year, you already had really a tinderbox. It was ready to go, especially for a viral threat, for a biological threat. Why? You had people packed into places which were more like warehouses for people than they were like healthcare facilities. They were being cared for by people who didn't have the time to make sure that they were clean and that they weren't passing on infections, or even able to see when they were getting a pneumonia, when it was time to go to a hospital. That was sort of the fertile ground that the virus found itself in. That's why this wasn't just a question of a lucky virus or unlucky virus that struck us. It has to do with the conditions that we created before the virus ever came. There's another important sort of corollary to the financial imperatives that most of these facilities face that I wanted to just touch on, even though it's not directly related to COVID. And that is, I mentioned that in nursing homes, because most people have to get nursing home care paid for by federal subsidies or state subsidies, the facilities themselves have become experts in how to get that money and what kind of money they want. Medicare, which again covers up to maybe the first 100 days, is a relatively high level subsidy. It pays fairly well. Medi-Cal, which is California's version of Medicaid, a program for the poor, pays poorly. Nursing homes by law are not supposed to discriminate between people on Medicare and people on Medi-Cal. And so if you go into a facility on Medicare, you get that first 100 days reimbursed at the high rate, but then you have no money, you transition to Medi-Cal, it's supposed to make no difference, but it does to the facility, because you're gonna make them less money as a Medi-Cal patient, a poor person, than you did when you were on Medicare. And so they find ways to evict people when they make the transition from Medicare to Medi-Cal. How do they do that? If you're a woman with a UTI and you're delirious, they'll send you to the hospital so you don't even know what's going on. You don't even know that you've left the facility. They'll take people with cognitive impairments and put them in a wheelchair under an overpass. They will put them in motels, all to make room for more Medicare patients and to get rid of Medi-Cal patients. There are laws that protect people in this situation. We at CANHR provide people assistance in this kind of situation all the time, but we're only able to do it if people know that what the facilities are doing is illegal, and mostly they don't know. And so outreach and education to people so they understand their rights is so important. Now I'm going to go back to sort of our broader theme. And so one sort of recurrent theme that you see in congressional investigations and newspaper discussions of the nursing home industry is this notion that all nursing homes are poor. They're doing the best they can, but they have these subsidies and they just run out of money. And so we shouldn't blame them for the terrible conditions that exist in them. Well, then why is it that in California and across the country, there are billionaires, people who made their money running nursing homes? Where did that money come from? And here's the answer. Nursing homes need lots of different services. Sometimes they lease the land that the facility sits on. They need to get medical devices, equipment, and stuff delivered to them for their patients. And those companies are also owned by the nursing home owner. And so if you're the owner of the nursing home, but you also own the lease company, you also own the medical supply company, there are lots of ways that you can suck up that Medicare and Medi-Cal revenue without it ever even hitting the books of the nursing home itself. The money just goes back out to the owner. And as a result, you can have nursing homes that look like they're just barely in the black or even losing money, but they're immensely profitable to the people who run them because of all of the related party services that are going on at the same time. So be skeptical when you hear of a solution which involves, well, let's just give more money to nursing homes in these subsidies, because the money is not going to go for patient care. The money is going to go for a new Lamborghini. We've got to do better than that in trying to figure out how to improve conditions for people. A related and important question is, so, it's really the regulators. Yeah, there's lots of like bad businesses or businesses that are kind of immoral and they want to make money and they may not care how they do it. But what we mostly hope for in a capitalist country with safety rails like the United States is that there's good regulators, because regulators will be there to capture bad conduct, right? Mostly not right. Unfortunately, not with nursing homes. Here's why. There are very good laws in California and in fact across the country regulating nursing homes, regulating staffing, regulating care that's supposed to be provided and so on. But they are very poorly enforced, meaning there's very poor oversight and very few consequences for violations of those rules. Take infection control. If there was one thing that you think would be nice that nursing homes take seriously, it would be infection control. One way to do that is to have significant penalties for infection control violations when these places are inspected by surveyors and nursing home nurses, regulator nurses. The actual monetary penalty for an infection control violation before the COVID pandemic and during the COVID pandemic was zero. You just had to submit a plan, how are you going to fix it? But no, you didn't have to pay a penalty. Why? Well, because we all know infection control is not that important, right? Nursing home industry learns what we teach them. It learns what regulators teach them. If regulators say, we don't think an infection control violation is serious enough to deserve a monetary penalty, nursing home industry, they're like, okay, so we're not going to take infection control very seriously, even if we see what that meant for 180,000 nursing home residents over the last year, their lives. And that still has not changed. Another way to assess what the regulators are doing, looking at complaints. In California, it takes on average 636 days, 2 years, to investigate a nursing home complaint. What does that mean practically? Someone files a complaint about neglect or abuse in a nursing home. The regulators take 2 years to check it out. In 2 years, the staff involved have been gone for years. Remember, 130% turnover? There's no witnesses. The resident may be dead or maybe moved. So what the regulators do is they just close the case. They say it's not substantiated, which means it's too late for them to find any evidence. In LA, it's 1,000 days for a nursing home complaint to be investigated. It's a travesty, and it's something that the Los Angeles County Office of the Inspector General is trying to do something about. So there's a current backlog of something like 13,000 complaints against nursing homes that have built up. So I'm going to transition now to a little bit of optimism, and there'll be more optimism from Pauline, I promise. One crazy silver lining to this disaster we have had in the last year is the way it has focused the public's attention on what goes on behind closed doors in nursing homes like it never has been before. We had TV and news and radio coverage of nursing homes like we haven't seen at CANHR in decades. It just didn't exist before. People saw bodies coming out of these facilities and they started to ask questions. And as a result, we really saw a significant movement towards legislation attempting to fix some of these broad structural problems we've been talking about. One of them is a way of permitting plaintiffs who are suing nursing homes to collect $500 for each violation of a resident's rights. What does that mean? It used to be, crazily enough, that if, say, a nursing home wasn't bothering fixing its air conditioning, and so all 90 residents were suffering in 100-degree heat in their room every day through a summer in LA, that was one $500 violation. Remember, nursing homes learn what we teach them. So one $500 violation versus the cost of fixing those air conditioners, it's a no-brainer. They're not gonna fix them. This AB 849 would say it would be $500 per person, because of course it should be. Each individual person at the facility is suffering through those conditions, and they should be able to be compensated for that in civil court. Why in civil court? Because they're not getting relief from the regulators. So plaintiffs filing lawsuits, even though that's an inefficient way of regulation, that may be the only way right now of getting some of these nursing homes to change. Another one, AB 1502, it's now on kind of a slow track. It's gonna be, it's now a 2-year bill. It still could pass in the next year, we will see. It is intended to address another crazy feature of California's nursing home system, which is that if you, Marsha, or you, Suyin, wanted to go out and buy a nursing home, you could do it right now. And you could run it for years with no training, maybe you haven't, no training, no experience running nursing homes, knowing nothing about the treatment of elderly or ill individuals. It is harder to become a dog groomer in California than it is to become a nursing home owner. And that's because the state permits operators to simply buy the license of the previous owner and continue operating it. Think about that. Say you're a school bus driver and you weren't really licensed to drive the school bus, you just bought the license of the old school bus driver. That would be madness. We would stop it in a minute, right? Because kids' lives are at stake. How is it that we think in a different way about the lives of our elderly and disabled people in long-term care? It's a scandal. And it's something that AB 1502 hopefully will address if we get to it. That was a lot of kind of like darkness, but there is some move towards new legislation. I want to flip it to Pauline now to talk about how people find themselves in nursing homes, but crucially how they find their way out. And I got to unshare the screen. Or Pauline, are you good?
Let's see. PowerPoint. This one. One moment. I am on a different computer and now it's saying I have some security.
I can open it and you can just direct me to go through. You want to do that?
Okay. Yeah.
Oh, hang on one second. Let me just open it.
Thanks. Yeah, I'm at work today, so I have a different computer.
Yeah, no worries. And Pauline. Just bear with me one second. I'm just going to pull this up. Let me find this. Here it is. Okay, one second. And
see, mine's a pro now.
Open. And now I'm going to open on, hang on, I got to share screen. Oh, crap. Sorry, I'm doing this very inefficiently. Crap. Bear with me, sorry guys. Everything looks weird. Okay, so now I share screen. I'm screen sharing. Are you good? Do you have this now, Pauline?
No, not yet.
Try again, Mike.
There we go.
Oh,
You guys got it?
there. Yeah.
Okay.
Okay.
Just tell me when you want to go on.
Okay. So after all of those horrible things that you just heard, why would an individual even seek care in a nursing home? And a lot of times it's because it feels like there is no other option. People may have the need for round-the-clock skilled nursing care. And there is a federal institutional bias, which means that the federal law requires that we provide skilled nursing services for whoever needs it, compared to home and community-based services. Providing those services are actually optional. It's not required for the state or federal government to provide those services. So there are some, and I will talk about those, but we definitely need more. Lack of family support. A lot of people are working, and even if their loved one is living with them, if that person needs supervision or assistance throughout the day and they're working, they're not able to take care of their loved one, and they may be looking for placement in a nursing home. Lack of financial resources. So the annual private pay rate for a nursing home is over $10,000 a month, but 60% of people in nursing homes are actually on Medi-Cal. For Medi-Cal, income isn't really a limiting factor. As long as your income is less than the private pay rate, your monthly income, and you can get your resources down, and I'll go over what those limits are, then you can qualify for Medi-Cal in a nursing home. And it's much easier to qualify for Medi-Cal in a nursing home than it is to qualify for Medi-Cal in the community, because those income and asset limits are much stricter for people who are in the community trying to access Medi-Cal. And even though there are home and community-based services programs, there may be a lack of available services and supports in your community. So maybe in your county, in your city, there may just not be enough to give somebody the amount of care that they need. So unfortunately, even though no one says, I want to go into a nursing home someday, for some people, it seems like the only option. But as we move on, I think especially as this pandemic has shed light on how terrible the situation is in nursing homes, there really is a movement to provide more alternatives. If you can go down a little more, Mike, so I can see.
That's great. I'm on page. Oh shit. Oh, excuse me. Here we go.
A little bit up more.
Up.
So what are the alternatives? They're called home and community-based services. It's long-term healthcare services and supports provided in the recipient's home or in an integrated community setting, provided as an alternative to institutional care. If you can go to the next slide. So in 1999, the Supreme Court concluded that according to the American with Disabilities Act, people with disabilities have the right to receive state-funded supports and services in the community rather than institutions, as long as the placement is appropriate, the person does not refuse placement or living in the community, and where the services are available. This picture here on the right is the two women who were the plaintiffs. They were in and out of mental institutions, really wanting to just be part of the community. Unfortunately, the lack of services prevented them from doing so. until they brought this lawsuit, and then they were able to prioritize home and community-based services and providing resources to people to let them be part of the community. Next slide, Mike. So if I were to really get deep into all the home and community-based services, it would take a very long time. I'm just going to give you a quick overview today. But if you do have any follow-up questions on the programs, you're welcome to email me or call us at CANHR. So most of these programs, home and community-based services, they are paid for by Medi-Cal. So these are programs, some of them are paid for by Medicare also, but most of these you need to have Medi-Cal eligibility. So community first choice option, I don't know if you've heard of in-home supportive services before. That is a personal care services program that you can get an attendant to come and help you with activities of daily living, like assisting with hygiene, maybe doing grocery shopping, some cleaning in the house, prompting you to take your medications. And so community first choice option is a program within IHSS, in-home supportive services. And the difference between the regular IHSS programs and community first choice option is it requires an institutional level of care. And so what happens is when you call in-home supportive services to be assessed, if you need a higher level of care during the assessment, then they will place you into this program, community first choice option. So this is statewide. There are no wait lists. If you are in your county and you apply and you need the services and you're eligible, you will get access to these services. There is no enrollment cap, and you would contact in-home supportive services to get the assessment done and to sign up. CANHR has a fact sheet on our website that provides the phone numbers to each county office and also more information about the program. And this program is not subject to Medi-Cal Recovery. Medi-Cal Recovery is a recovery program where if someone is in a skilled nursing facility, or if someone is enrolled in some of these home and community-based programs that provide skilled nursing types of services at home, Medi-Cal can seek to be reimbursed for what they paid out if there's anything left in your estate. We have a booklet on Medi-Cal Recovery if you're interested in learning more about that. So community first choice option is probably one of the easier programs to get into. One of the downsides to this program is most people do not feel that they get the adequate amount of hours that they need. So if you feel that you need 14 hours a week, you may get 8 hours, or it just depends. They're going to do the assessment and you're not going to know what you get until they do the assessment. There's always an opportunity to appeal for more hours, but you'll have to find out what you get first and then appeal. Okay, program for all-inclusive care for the elderly, that is known as the PACE program. There are PACE centers around our area. There's one in San Francisco on Bush Street. CANHR does have a fact sheet about this as well. For this program, you need dual eligibility, meaning you need to be eligible for Medicare and Medi-Cal. You could just be eligible for Medicare, but you're going to have to pay the difference. And I've heard for people paying the difference, it's maybe around $5,000 a month or something very expensive. So it's more feasible if you are on Medi-Cal. You need to be 55 or older, and it's only available in 13 counties, and zip codes are restricted. So when you look it up, you have to see if your address falls within the proper zip code. There is no enrollment cap. The limiting factor is really the locations. Somebody commented about community first choice option. A person who needs a higher level of care will never get enough hours through this program. I agree. If you need 24-hour care, you're not really going to get that through community first choice option. But what does happen is there's another program that I will go over later that people apply to in addition to the home and community first choice option to get more hours if they're gravely disabled. So for the PACE program, the centers are really beautiful. You can get acupuncture on site. There's a clinic on site. So you can go to your doctor's appointments while you're at the adult day center. They provide physical therapy. So you're going to get all the services that you need during the day. They also will do laundry. They provide meals at the center, and they also send meals to the individuals' homes for the days that they're not at the center. Usually, if they're at the center 3 days a week, but again, it's limited by county, and you have to be over 55. The California Community Transitions Program. This program, so it was 90 days. You had to spend 90 days in an institution before you were eligible. In January, that changed to 60 days. And it will be, right now, during COVID, I believe there's even more flexibility, and it may be even less days required in an institution. So what California Community Transitions does is it helps people transition from a nursing home to the community. So they provide funding to, say you need to put a deposit on an apartment, say you need to modify your home with grab bars or a ramp, say you need furniture to move into that home. They will assess what your needs are to safely transition to the community, come up with a care plan, and assist in paying. We've had people who have had them pay for their whole deposit, their living room set, their plates, things like that, so that they can transition, and then they connect them with other programs, for example, IHSS Community First Choice option, or some of the other programs that I'm going to go over later, to make sure that once they transition, that they're able to get the services they need through another program. The Community Transitions Program is just that. It's a transitions program. So usually their goal is to transition somebody within a set period of time. So to apply for the Community Transitions Program, you would want to go to the California Community Transitions Program, and they have something called lead organizations, and you have to apply through a lead organization. Somebody asked, if a senior isn't Medi-Cal eligible, can that person participate in these programs and pay for services? In some of them you can, not all of them. So community first choice option, you wouldn't be able to pay out of pocket, but you would be able to for the PACE program. You would not be able to pay out of pocket for community transitions or assisted living waiver, but you can for CBAS, which is a day care program. Okay, so now we're at, and with the California Community Transitions, that was statewide. So with that program, it's not an issue to get into that program. The problem with home and community-based services is if you can get into them, it's great, but for a lot of them, it's difficult to get into, or the services are limited. So California Community Transitions is more of it's helping you transition, and it's not going to be the final ultimate program that you're in, but I've seen them do a lot for people wanting to transition and really helping them get the financial resources to make that big move. The assisted living waiver. So this is when you have somebody that is at an institutional level of care, but they do not want to be in a nursing home. So the assisted living waiver, if you're signed up for the assisted living waiver, you would pay the assisted living facility a certain rate, which is around $1,000 a month. And what Medi-Cal does is they pay for the additional skilled nursing services that you need to be able to stay at the assisted living at the assisted living facility safely. This program is limited. There is a wait list. They're waiting for additional slots. So you can get on the wait list now, but it's going to be a period of time before they'll even review your application. So this, if you are interested in this program, I would also recommend, if you need help right away, looking into a backup plan, because it could be months, it could be years, especially if you're coming from the community. It's going to take longer to get into this program. Whereas if you're coming from a skilled nursing facility, they're going to prioritize your application and you're going to get into the assisted living waiver program more quickly. Let's see, multi-purpose senior services program. That is more like a case management. So that program will do an assessment of what your needs are, write up a care plan of what kinds of services you need to be in the community safely, but their budget is very small. So you're not gonna, basically you're gonna get a care plan, and I think their budget is around $4,000 per person for the whole year. So it's really, that kind of program would benefit somebody if they're using it in addition to, for example, in-home supportive services. On its own, it's more of a case management. And to apply, you would contact the multi-purpose senior services program. There are wait lists, but it depends on the counties. You have to be older than 65. And you'll notice these three programs are subject to Medi-Cal recovery. So that doesn't mean that you shouldn't apply, but it means you should learn about how to avoid Medi-Cal recovery so that your estate isn't subject to Medi-Cal recovery after you die. Oh, Gina Sofsky asks, so with the ALW waiver program, the applicant has a copay of about $1,000. Yes, so the applicant pays the SSI board and care rate, which is, it's a little bit over $1,000. It goes up a little bit every year. And so the participant would need to pay that, and Medi-Cal would pay for the additional services. The other thing to keep in mind with the assisted living waiver, it says on the slide that you have to have no share of cost Medi-Cal. So that is the strictest, that one has the strictest Medi-Cal eligibility requirements. So if you have a high income, then you're going to not be eligible for this program. And so I know I'm going over this very quickly and there's a lot of information, but my point is so that you know these programs exist. And if you want to know more about them, you can call us at our 1-800 number. You can call and ask to speak to me or another advocate if you want somebody to go through the programs with you individually and figure out what would make sense for you. So we are available to do that. So back to, sorry, Mike, can you go up a little bit? Oh, home and community-based alternatives waiver. So that program, if you are gravely disabled, that is the program that's going to provide the most hours. It's going to provide the highest level of care. So if you, it can pay for RN hours. It can pay for CNA hours. And what they'll usually have you do with the home and community-based alternatives waiver is they'll actually have you apply for IHSS as well, see how many hours you get through the IHSS program, and then they'll provide you with additional hours to supplement that, the type of care that you need. And so this program is for people who are high needs, usually coming from a nursing home or a hospital. That's going to be the easiest way to get into this program. Otherwise, you're going to be on the wait list for a very long time. And you would, to apply, you would contact a care coordination agency. So you would go to the home and community-based alternatives waiver website, contact the care coordination agency, and from there, you would call them. They would explain the program to you, do an assessment, and figure out what services that you're eligible for. So the main thing to keep in mind with all these programs is there's an array of services that they all provide, but you don't know what you're going to get until you do an assessment. And even though these are all called home and community-based services, you have to apply to each program separately. There's not a one-door policy right now, which is why it makes it very complicated, one, to explain this to a group of people, or even for people applying individually. It's very confusing and complicated because it's all these different programs with all these generic names. And basically what you're going to want to do is talk to somebody who knows about the different programs, can hear what your needs are, and help guide you in the right direction based on your age, where you live, the kinds of services you need. And then after that, you would apply to the program, and you have to get the assessment and wait and find out what services they're going to give you. Because even if there's a long list of services, it's not guaranteed that they're going to find you eligible for those or assign them to you. And then, like I said, each program, it's a different application process. You have to apply at a different place. There's not a one-door policy. So you have to actually figure out which program is right for you and then go and apply to them directly. So I know that sounds complicated and frustrating, but at the same time, whenever I've spoken to somebody who's actually enrolled in the program, they're very happy. They're much happier than when they were in an institution. They really feel part of the community, and they feel like there's a sense of dignity that they've had returned to them. Let's see if you can go down more. Community-based adult services is a adult day healthcare program. And so for this program, you would sign up, you would go to a center maybe 3 days a week. They have activities, they provide you with meals. They do have different services available. They have a team that does an assessment, does a care plan, and figures out what kind of care that you need. And so for this program, what you'll notice is when you apply, there's actually many different community-based adult services centers. And so what you have to do is call them and figure out which one's right for you. For example, I spent time calling calling a couple in San Francisco, and some specifically catered to a Russian-speaking population, or some specifically catered to people with dementia. So it just really depends. All the centers are a little bit specialized, and so you're going to want to call and see if it's the right fit. And with this program, it's run by the Department on Aging. So you would go to the Department on Aging website and you can apply, and then you have to contact all the different centers to see what's appropriate for you. These other home and community-based services programs that I listed on the right-hand side, those I'm not going to get into. They're even more complicated than the ones that I just explained. But that's it on the programs. We can move into questions. Like I said before, there's a Medi-Cal requirement. So I just put, here's some Medi-Cal eligibility categories. Again, this kind of information is really, you have to speak to each individual and figure out what their income and assets are. So usually what I do is I have somebody, if somebody calls me and says, I want to know if I'm eligible for Medi-Cal, I ask that they call me, know what their income is, whose income comes in whose name. For example, if it's a married couple, I ask the husband and spouse to know what kind of income they have, what income comes in each of their names, what they have in assets, so we can figure out what's exempt, what counts for Medi-Cal, what doesn't. And then from there, we figure out what category they may fit in, what their share of costs may be. And if their situation is too complicated, we have a lawyer referral service, and we refer them to an estate planner to help them apply for Medi-Cal. But in many of the cases, we're able to help them figure out if they qualify. And pretty much this is just a sample of the Medi-Cal application. But that's just a sample. Of course, if you do want to know more about these, I would recommend calling us. And there is hope for an expansion of home and community-based services. The Better Care Jobs Act is looking to expand access to personal care services, and they're looking at increasing the financial eligibility limits, enabling 3.2 million additional people to access HCBS. They want to create 500,000 new jobs for direct care workers. So we don't know what this means for California specifically, but it looks like good news for home and community-based services, and like there will be more options for people in the future so that they can choose to avoid skilled nursing facilities. Okay, that's about it from me.
Okay, thank you very much to both of you for this very important and actually also very interesting presentation. We have a few questions here. The first question I have here is how to find in-home care for people with long-term insurance. I don't know who wants to.
Hey, Pauline, why don't you take that?
So we don't actually, we don't have any suggestions on home care agencies. I would say, you know, so we pretty much cover assisted living, skilled nursing facilities, Medi-Cal services, but we don't have a lot of knowledge in home care. So I wouldn't be able to answer that question.
Okay, so the next question was.
Let me just say that Ashby Village does have a lot of information about home care agencies. So if any members need that information, they can contact the social care team at Ashby Village.
Okay, that's good to know. And there was one question for Pauline. Did Pauline say 50 days or 60 days in institution for the Common Transitions Program? Community Transitions Program.
It's 60 days, but right now during the pandemic, I believe that's even more flexible. So if you've been in less days and while we're still in the public health emergency, I would recommend calling them even if it hasn't been 60 days, because there's a lot more flexibility right now, but it will eventually go back to 60 days.
Okay.
I'd also suggest, especially with the last question, people can check out Choice in Aging, which is an organization, it's a nonprofit that is, I think, based in Contra Costa, but helps people throughout the Bay Area with issues around finding care. So that might be useful too.
Another question was, if a senior isn't Medi-Cal eligible, can that person participate in these programs and pay for the services?
For some of the programs, yes, but not all of the programs. Some of the programs are Medi-Cal specific, but like CBAS, community-based adult services, the adult day healthcare, that you can pay for privately. PACE, you can pay to go to that center privately. So some of them, yes, but unfortunately not all of them.
So with the ALW waiver program, the applicant has a copay of about $1,000. That was the question.
Yes, they do have a copay. So that may be, you know, something that may be a deterrent to some people, but from most of the people I've talked to that are in the assisted living waiver program, they really love the program and the services they're getting in less of an institutional setting, but they do need to pay. It's a little bit over $1,000. It's the SSI board and care rate, and so Medi-Cal pays the difference.
Okay. And here's actually a comment. And it says here, I'm a retired CDPH health facility evaluator nurse who inspected Northern California facilities in the Chico district, including many nursing homes from 2009 to 15. I enthusiastically and thankfully applaud this presentation. And I would add that the fight for reform has to include fighting for CDPH licensing and certification administrators to increase increase recruiting of qualified nurses with area equivalent wages and benefits. And we must fight for more accountability from the CDPH managers and administrators.
We would say a big amen to that. So thank you for that.
Yeah, so another question was, for those who will not be financially eligible for Medi-Cal at the time of need for many of these services, and let's say not for a couple of years, where would we go for counseling or find out which services comparable to those you've mentioned are available to them?
So I would give us a call so we could just take a look at, I think there's also a misconception about how strict Medi-Cal eligibility is. A lot of people don't realize that their home is an exempt asset, that many assets that they have, like retirement accounts, are exempt. So they may be eligible for Medi-Cal sooner than they think. And because there was also a budget bill passed that they're eliminating the asset test for Medi-Cal. So it's going to be mostly based on income. So I would say give us a call just if you want to see where you're at as far as Medi-Cal eligibility. Otherwise, if you're just looking for community services that you can pay for privately, maybe the Department on Aging, I believe, has some information about that.
Yeah, and I would add to that, even with income, I have learned from Pauline that there's lots of things that you can do to try to manage income eligibility as well. For example, by buying insurance. So if you have to make monthly or quarterly insurance payments, that can bring your income level down and still have a benefit for you. So I would say don't throw up your hands and give up if you think that you don't meet the requirements, because there's probably things that you can do to meet them.
There's one question, I think that's a question for you, Michael. We have been paying for a long-term care for years, but we only created a plan for nursing home care. We wanted to transition it to home care support, but were told we couldn't make the change after 75 years old. Do you think that this is illegal?
I don't think it's illegal. I think it's immoral. And it's why your organization and CANHR and others like us are working so hard to sort of change the thinking. And again, it's wrong to find too many silver linings in COVID, but there are a lot of empty beds in nursing homes right now, both because people have died, but also crucially, because families are no longer willing to put their loved ones at risk and put them into these congregate settings. And I think that is really putting a lot of energy behind exploring alternatives. And many of them may be cheaper for us as a society than subsidizing care in nursing homes.
A more general question, I think you already answered that anyway. Can anyone contact your agency for additional information? I guess yes, right?
Yes, I will say that right now our phones are transitioning. So I've heard some people are calling and have a hard time getting through. So I would say I would try calling us on Monday. I think by then our phone issue will be resolved. Or you can email us at canhrmail@canhr.org, and I can put that into the chat.
Yeah, that was actually one question too. What's the phone number for CANHR? And so, yeah, you're transitioning right now. I mean, you're moving, so the phone number probably changes too, right?
It'll be the same phone number. It's just for some reason our phones are having a hard time.
Yeah, it might be better to just kind of like to contact you through your email, right?
Yes,
At
exactly.
Yeah. I think this is now the last question, and it's kind of a specific question. Could you provide info about premature discharge from SNF facilities, so skilled nursing facilities, especially JIMO versus Sibelius, not part of this presentation, but maybe providing fact sheet to Ashby Village? I mean, that seems very specific, so.
Yeah, well, so while it's a specific question, it is a general problem. And we would be happy to send Ashby Village some information on nursing home evictions and how to fight them. A couple quick things though to understand. They're almost always driven by profit incentives, like we talked about earlier, because what they want to do is get Medi-Cal patients out, get Medicare patients in. However, there are an awful lot of protections that exist to prevent facilities from doing these illegal evictions. Evictions should only happen if someone is so well they can go home, or if the facility is closing under certain circumstances. But almost everything else isn't a good reason. Sometimes facilities will say, we only have short-term beds, by which they mean we only want to have Medicare patients, but that's illegal. There is no such thing as a short-term bed in a nursing home in California. So I would suggest that anybody who's having problems with an eviction gets an eviction notice. This is something we do every day of the week. We help people file complaints. We negotiate with facilities. We do all this for free, and we have a lot of resources and information. So please give us a call.
Yeah, so that was actually the last question, but I want to mention that there were quite a few comments in the chat box and congratulating you or saying, I mean, thank you for all the good work you do and for a really great presentation. And yeah, I agree. It was really
a great pleasure meeting all of you. And thanks so much for the energy that you, Ashby Village, have put into putting this program together.
So now to Roberta, who has the last word.
Okay, can you hear me now? Yeah. Thank you both. That was a wonderful presentation and a really important one, and will give us great things to think about, particularly at our Elder Action meeting. I also want to thank Sigrid, who did a great job as usual with our questions, not an easy task. And a big shout out to Suyan Beckner from our staff, who makes sure all our tech works properly. Before we end today, though, I also want to let all of you know that next Tuesday at the same time, so Tuesday, August 17th at 10:30 a.m., Ashby Village will be having another presentation on a very interesting new pilot project called My Nurse. We are only one of 4 California villages to be piloting this program. It's funded by Medicare and free to us all, except for people currently enrolled in Kaiser Permanente healthcare. For those of you dealing with chronic health issues such as diabetes, high blood pressure, or other chronic issues, this program will give you the support you need through weekly or biweekly contact with a nurse who will also be in contact with your doctor should he or she become aware of changes in your conditions that might merit a consult with your doctor. So do join us. It's a really interesting program, and you can find all about it next Tuesday at 10:30, and you can register through the calendar or call the office at 204-9200. Or through events at ashbyvillage.org. Thank all of you. I believe the Elder Action Now email contact is in our chat. If any of you want to get involved with Elder Action and to volunteer for the member support teams or get help from us, you can contact Avi Rose at ashbyvillage.org. Thank you all. Have a great rest of your morning.